Shall we do the questions afterwards now?
Absolutely.
Because we're running out of time.
Absolutely.
Oh, Jamal.
Okay, our next presenter is Dr. Qiqi Yin. She's going to speak about the KeyCort study, an international E-Delphi study on the treatment of keloids using intralesional corticosteroids in clinical practice. Thank you.
Thank you for the introduction. And yeah, indeed, today my presentation is about the intralesional corticosteroid administration in keloids. So first of all, what's already known? Well, intralesional corticosteroids are considered as first-line keloid treatment, used very frequently, and this has already been so for decades. Corticosteroids have different effects, including but not limited to the suppression of inflammation, vasoconstriction, and different effects on the extracellular matrix, such as inhibition of collagen formation and degradation of collagen. And even though the intralesional corticosteroid treatment are considered as first-line keloid treatment, the therapeutic effect is still very variable and not always optimal. And we thought that this could at least partly be clarified by the large variety in operator-dependent factors. And so what are those factors? And in the coming slides, I'm going to give some examples of the variations. So first of all, the type of corticosteroid. As you can see, many different corticosteroids can be injected intralesionally. And why would you choose one over the other? And even though in clinical practice, this may depend largely on your experience and practical reasons, there may be other factors that should be considered. And this is a table with the half-lives of different types of corticosteroids after intramuscular injection. Yeah, actually due to lack of data on intradermal injection or injection into keloid tissue. And even though we cannot extrapolate those numbers to keloid tissue or intradermal data, the differences between the numbers are very interesting. And as you can see, triamcinolone acetonide has the longest half-lives, which may be relevant for treating chronic skin disorders such as keloids. Then we were also interested in the needle and syringe size. As you can see, there are many variations of them. And why is this relevant? Well, because the needle and syringe size determines the force that is needed to create a certain pressure in order to inject a certain amount of drugs. And for the syringe, this can be illustrated with Pascal's law. And Pascal's law practically says when the diameter of a syringe is 2 times as large, and when the thumb force is kept constant, then the created pressure will be 4 times as small. And when the diameter of the syringe plunger is 3 times as large, and when the thumb force is kept constant, then the generated pressure will be 9 times as small. So that means that a much larger thumb force is needed in order to create the same pressure in order to inject the same amount of drugs into the keloid. Then, considering local anesthesia, we found 3 RCTs that looked on the injection pain after intralesional corticosteroid administration. One study investigated a one-on-one mix with lidocaine 1% and triamcinolone compared to amla cream. And this study found that amla cream did decrease the needle puncture pain, whereas the one-on-one mix and of lidocaine 1% and triamcinolone did not. However, when we looked at the infiltration pain, so during injection, then we saw that both methods did not have any effect on the injection pain when compared to placebo. Then other 2 studies looked at skin cooling prior to injection, and both studies found that skin cooling prior to injection would decrease both needle puncture pain, as well as the infiltration pain. And considering the field block anesthesia, no published studies were identified. This is an interesting study actually about the treatment interval. This study looked at the volume change of 16 different keloids following a single injection of triamcinolone 40 milligrams. They looked at the weekly volume change. And in the first 2 weeks, this volume change, the volume decrease was the largest. And after 4 weeks, they saw that the volume would gradually increase again. Then considering the manual injection techniques, there are many variations as well, such as where exactly to inject, the speed of injection, different endpoints such as the blanching phenomenon, and more. So in order to map all the different aspects of the intralesional corticosteroid treatment, we looked broadly into the literature, performed a scoping review, and here we included RCTs only because of the strongest evidence of those studies. And in all those studies, we found that there was incomplete reporting as well as a substantial heterogeneity. So for example, we wanted to compare the dosing of triamcinolone between studies as determined by the used volume multiplied by the used concentration. And this was only possible or only reported in 1/4 of the studies. And in those 10 studies, there was also a very large dose difference of 20 times. So whereas one study would inject 1 milligram per square centimeter, the other study would inject 20 milligrams per square centimeters, which is an incredibly large dose difference, and that in RCTs which are supposed to be having the strongest evidence. There was also a large difference in the maximum dosing treatment interval. 1 out of 5 studies used pain reduction prior to treatment, and very few studies reported on details of needles, needle size, syringe size, and location of injection. And we concluded that more uniformity in the intralesional corticosteroid administration is needed. So the next step was to look into how things are done in current clinical practice, and we performed a survey study among dermatologists and plastic surgeons in the Netherlands. And it appeared that almost everyone would use triamcinolone acetonide as corticosteroid for injection. However, on all other aspects of the intralesional corticosteroid administration, there was a very large variety. So in dosing, in pain reduction prior to treatment, treatment interval, syringe and needle size choice, and also the location of injection. And this large variation in intralesional corticosteroid administration and dosage may at least partly explain the variable treatment outcomes for keloids. And since currently, based on the studies that we have, we cannot give strong evidence-based recommendations, we thought it was useful to perform a IDELPHI study, aiming to reach consensus on the various aspects of the intralesional corticosteroid treatment for keloids among international keloid experts. This study consisted of 2 Delphi rounds, followed by a consensus meeting, and in total, 12 dermatologists and 11 plastic surgeons joined the expert panel worldwide, voted on 30 statements, and consensus was defined as more than 75% or more choosing voting for agree or strongly agree on a 7-point Likert scale. And eventually, consensus was reached over 20 statements. And in the following slides, I'm going to walk you through the statements on which we voted. So first of all, consensus was reached on treatment goals, that pain reduction, itch reduction, and prevention or treatment of functional impairment should be discussed with the patient prior to treatment, keloid treatment, as well as the goal of maintaining a cosmetically acceptable appearance. Consensus was also reached that the intralesional corticosteroid administration with or without additional modalities is generally the first-line treatment for keloids smaller than 10 squared centimeters, with an elevation between 0.3 and 1 centimeters. And that triamcinolone acetonide is the preferred option here for the treatment based on its favorable pharmacokinetic properties and also the evidently larger available literature compared to the other corticosteroids. Considering the concentration, 40 milligrams per milliliters is generally the preferred concentration for treatment of a non-facial keloid. And with regard to the risk of systemic adverse events, consensus was reached that if a higher dose than 80 milligrams of triamcinolone per session is required for large keloids or multiple keloids, to then consider other treatment options or combining other treatment options. The suggested interval between treatment sessions with triamcinolone is 4 weeks. Shorter intervals may be indicated, but increase the risk for systemic and local side effects. And for children, dose reduction according to weight is recommended. Considering the syringe and needle size, consensus was reached that the syringe with a smaller inner diameter, generally 1 milliliter syringes, should be used for the injection, and a 25 gauge or 27 gauge needles are suggested for corticosteroid injection in keloids. Larger or smaller needles can be considered based on scar pliability and the use of any adjunctive measures, including laser pretreatments. Considering the local anesthesia, consensus was reached that minimizing pain during intralesional corticosteroid administration keloid should be aimed, as the treatment is often painful. Moreover, topical anesthetics, such as lidocaine, prilocaine cream, prior to treatment is an adequate option for reducing needle puncture pain, whereas diluting the intralesional corticosteroid with local anesthetic is not recommended for pain reduction. And finally, speed of corticosteroid injection should be taken into consideration for pain reduction. For the manual, considering the manual injection techniques, consensus was reached that observation of blanching determines the endpoint of infiltration when injecting directly into keloid tissue, with the side note that this is less noticeable in darker skin types. For very firm keloids, it can be considered to make multiple longitudinal or cross-sectional passes with a needle through the keloid, allowing for significant deposition of the corticosteroid within the needle tracts, and that care should be taken not to inject subcutaneously, as it increases the risk of subcutaneous atrophy. On some points, no consensus could be reached. First of all, the dosing per specific area in keloids. And this was mainly also because no consensus could be reached on how to determine the keloid size. And is that per square centimeters or per cubic centimeters? And more importantly, in the clinical practice, when there are time constraints, how to define how to measure the size. Consensus could also not be reached on the concentration of 10 milligram per milliliters as preferred concentration for treatment of a thin facial keloid, nor for the treatment of large keloids or multiple keloids when larger volumes are needed. And whereas we agreed that minimizing pain is important during keloid treatment, consensus could not be reached in which way to do so, whether that's using a field block anesthesia or skin cooling or lidocaine, prilocaine cream. And finally, consensus could not be reached on where exactly to inject into the keloid. The superficial part, margin, central part, and deep parts have all been mentioned. There are some limitations to the study, and I will name two of them. First of all, of course, the treatment response of intralesional corticosteroid administration in keloid is also dependent on other factors besides the operator-dependent factors, such as patient characteristics, but also keloid properties. And the recommendations are based on expert opinion, which is, of course, inherent to this type of study, instead of strong scientific evidence. So in summary, even though the intralesional corticosteroid treatment is considered as first-line keloid treatment, we see that the clinical practice is still very heterogeneous, as demonstrated by our survey among dermatologists and plastic surgeons in the Netherlands, which is still a very small geographic area. There is also, the literature is also incomplete and heterogeneous, as demonstrated by our scoping review, even in RCTs, which are supposed to be having the strongest evidence. And since, based on current studies, we cannot give strong evidence-based recommendations, we performed the eDelphi study, in which we reached consensus on treatment goals, type of corticosteroid and concentration, maximum dosing, treatment interval, needle and syringe size, minimizing pain during injection, and injection methods. And no consensus and also better understanding is needed on the location of injection, methods of pain reduction, and dosing per specific area. And by implementing the consensus recommendations, uniformity of intralesional corticosteroid administration keloid treatment will increase, and treatment results will be more comparable eventually. Thank you.